You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to subscribe on Apple Podcasts, Spotify, and anywhere you stream your podcasts. And connect with us on social media. You can follow the Journal on LinkedIn and be sure to follow the American Society of Addiction Medicine on Twitter and LinkedIn. Now let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Shawn McNiel, and today we're joined by Dr. Noa Krawczyk, who's an assistant professor in the Department of Population Health at the NYU Grossman School of Medicine. Dr. Krawczyk has an article in the March-April 2024 issue of the Journal of Addiction Medicine. It's entitled Initiatives to Support the Transition of Patients with Substance Use Disorders from Acute Care to Community-Based Services among a national sample of nonprofit hospitals. So, Dr. Krawczyk, welcome to the podcast. I want to thank you for being a guest, and I want to give you a moment to introduce yourself to our listeners and talk about how you became interested in the field of addiction.
Sure. So it was a little bit of a non-linear path, which is probably the case for most people. During my undergraduate years, I was studying biology, but started learning about public health, and a lot of my kind of coursework and interest started floating towards drug policy. I just found myself really interested in the topic. I did kind of a thesis project on drug users' right to treatment in jails and prisons, and so that just kind of sparked my curiosity. And then I actually started working in the field when I was doing some volunteer work in Brazil. I worked with a community-based organization during some time in college that was doing some work with people who are homeless and a lot of people who used crack cocaine, and I started becoming really interested in kind of what services were available for folks, and I linked up with an amazing epidemiology team in Brazil who was doing research on crack cocaine use and health services for people who use drugs. So I started doing research with them through a Fulbright fellowship that I had for a year, and I kind of never turned back. I came back to the U.S. to study substance use epidemiology and have been really focused on opioid use disorder mostly since then. But so yeah, that's a little bit of my kind of journey into this field.
Very good. That's a powerful story. Now, looking at your paper, you mentioned that it should be cost-effective to prevent acute healthcare needs and to prevent hospitalizations related to substance use disorders. So my next, logical question is, how do you feel, or who do you feel, would be the most logical entity to drive effective outpatient referrals? And I'm asking this, because there are some entities that might have an incentive for repeat customers. So who do you think should really be the one driving effective referrals?
Yeah, it's a great question. I guess there's two aspects of it. There's kind of the incentive piece, like are hospitalized incentivized enough from kind of a financial perspective to not want to see repeated hospitalizations? And I think there's some truth in terms of maybe some hospital systems are benefiting from people utilizing their services, but I think in many cases they're also really losing a lot of money and from a lot of these acute care hospitalizations. And of course, it depends on the patient population. It depends on, for example, if you're a Medicaid expansion state or not. But generally, and I'm definitely not a health economist, I do know that this does create somewhat of a burden for hospitals. So I do think that overall, from what I've kind of heard and from my work in the field, there is kind of an incentive on their end to not want to kind of see repeated hospitalizations, especially among people who are unfortunately often uninsured or underinsured and are kind of seen as a high cost to the system. So, but I think it's worthy of better understanding and more research around that and kind of in what situations that's really true versus maybe there isn't a system-wide incentive for that. But I think the second part of the question is really around kind of are hospitals even like the best equipped to do the transitions of care when really what you want is for folks to end up in a community-based treatment program or service that can kind of take care of them long term. And I think that there's like a lot of work that we need to do to understand I think probably how both of those entities could do it together rather than it being really falling on one, like the inpatient hospital side versus the outpatient side. I think it's impossible without some collaboration among both sides. But I think in the way that our system is set up, a lot of the care that people receive while they're in the hospital is coming from the hospitals themselves. So at least some of the initiation of the transition, I don't see how that could happen without their collaboration and kind of some input from that.
Yeah, that's a very good point. Now, do you believe that there needs to be more regulation in order to discourage readmissions? And do you feel that this would encourage hospitals to make more of an effort in coordinating post-discharge care?
Yeah, I think that's a great idea. I think there have been some attempts to do this through kind of incentives from insurance groups, as well as I think the Affordable Care Act also had some of these quality metrics, including reduction of readmissions as part of their kind of part of the changes that were implemented. And again, this is really not my area in terms of kind of the health economics part, but I do remember that there was really mixed findings around that. So it definitely wasn't clear that in itself kind of incentives, at least to hospitals, or maybe on the other hand, like punishment of hospitals in terms of readmissions had the effect that was hoped for. But I think there definitely needs to be better understanding of that, because I think you're right in terms of what you're getting at, that a lot of these kind of really changing system-wide how these services are provided likely depends a lot more on incentive structures and policies rather than on kind of, I think, what a lot of our interventions try and do, which is educate people and kind of do the more micro changes around how provision of care is delivered.
That's a really good point. Now, I want to look at some details from your study. So your study found that only about half, so 313 out of the 613 hospitals surveyed, prioritized substance use disorders as a community health need. So I'm a psychiatrist, so I might be a little bit biased, but those numbers seem a little bit low. And I'm wondering, what forces do you feel influence a hospital's perception of the impact of substance use disorders?
Yeah, I think that's I'm really glad you brought that up. And I honestly hadn't thought about that too much, because I think in the study we had been so focused on trying to understand and kind of this gap in services among those hospitals that do think that substance use is a problem, that I hadn't even spent a lot of time until I kind of saw your question about thinking like, wow, it really is only half of hospitals that even said this was one of their top 5 priorities areas, not even like their top priority area. So yeah, I do think that seems very low, especially with everything that's going on with the overdose crisis. Like, there's really no communities that this isn't affecting. So there's no way that these hospitals are not experiencing this issue in their communities. And I know that the way that these community health needs assessments are done, at least in theory, is supposed to involve some kind of community input. So the hospital system working with community organizations to try and understand what the community needs are. So it is very curious to see that this isn't coming up, and maybe that's because there's a lot of maybe other acute care needs or chronic care needs that are coming up more frequently for folks, but it's hard to believe that substance use wouldn't be up there. So maybe it's just really part of the stigma and people not paying attention as much to this as they maybe should in terms of the numbers and the numbers of people that it affects, or the age groups and populations that it's affecting.
Okay, and hopefully that evolves over time. So in doing your research and considering your study findings, what do you believe is the most effective strategy for establishing post-discharge care?
Yeah, I'm glad you're asking, because actually, so this study is part of a larger kind of portfolio of research that I'm trying to develop, which is really all around trying to answer that exact question: what is the most effective transition strategy or strategies? And I think we don't really have an answer to that yet. And part of what I'm trying to argue, I think, in this paper and in some of my other work, is that part of the reason we don't know is because there's been very little attention to the transitions piece of the equation. There's clearly a lot of kind of admission of that being important, but in terms of how it's studied or how it gets talked about that's really lacking. So I think it's going to be really hard for us to know what works if we're not studying it more effectively. And we have tried to start doing that with some studies. So for example, in a different study we just completed, we actually did a Delphi panel with many experts in the addiction field and the transitions of care field to actually just ask them what types of transition strategies they thought were most effective, which was really illuminating. And of course, this is based on people's opinions and not necessarily kind of empirically tested studies, but we did find kind of some indication of strategies that were most effective, at least that are kind of being utilized, and people have some at least anecdotal information about, and some research is coming out about them. And they usually tend to be really focused on first making sure medications are given directly in the hospital. So that's definitely one that I think we're seeing more and more research about, being clearly associated with people continuing treatment in the community, as well as actually giving people bridge prescriptions for medications, either in hand or either the medication directly or as a prescription once they leave. So there's definitely a lot of, I think we know that making sure people have the medication and don't have lapse in that is very important. I think in terms of other strategies and supports, I think there's still a lot that we need to better understand. So hoping I can answer that question a little bit better in a few years when some of this data comes out.
Okay. And really several of the things you said sound like they would lower readmission rates. So what clinical advice might you have for providers who are listening, who treat substance use disorders on the basis of what you found in your study?
So I don't know if I can speak to that directly. I'm also not a clinician, so don't have kind of the clinical experience, but I think one thing I would love providers to be doing more is paying attention to the transition pieces in terms of, first of all, the way that they're developing their program. So one thing that we found in the study is that the majority of hospitals that did say that they were transitioning patients or referring or linking patients to ongoing treatment didn't specify how that was done. So I would really encourage people to be very specific in terms of their processes. If they are planning on linking patients to ongoing care, have a protocol for that, have a process for that, so that we can kind of better understand what works or doesn't work, and how folks are doing that a little bit better. So that's one thing. I think the second piece is also to, that's for how we can study it, but also really pay attention to kind of what can be done in terms of making that transition as smooth as possible. And there's been a lot of kind of low-hanging fruit interventions that we know have not been super effective. So like SBIRT is one that we know a lot of hospitals adopt, but the referral to treatment, which is the RT of the SBIRT, has really been very neglected and has not shown to be very effective. So I think rather than just focusing on what happens during the hospitalization or the kind of emergency department visit, really think about, what is being done to make sure that the patient has enough supports to continue treatment. I know it's a very general question, but I think we just haven't really focused on it enough, and it's great to hear that people are interested in this. That's kind of, I think we just need to really ramp up our attention to this. Good.
And I did leave that question very general, but I think you made some really great points that would be useful to clinicians. Now, are there any other details from your paper that you would like to highlight?
I would just say, I hope that transitions of care can continue to be something that we're paying more attention to and investing more resources in, both in terms of kind of the type of staff that are involved, making sure people have time and resource to actually develop some of those transitions of care. I think one thing that we saw is that a lot of time it's the physicians themselves that are facilitating some kind of transition. In some cases, it's other types of staff. So really thinking kind of what the best models of care are in terms of who's involved in facilitating transitions is another big kind of piece of this that will be important to further develop as well.
Okay, very good. Well, It's been a pleasure, Dr. Krawczyk, having you on the podcast today, and thank you so much for coming on and sharing your work.
No, thank you so much for featuring this paper. It's great to hear about the interest, and I hope we get to connect another time.
Absolutely. Now, one more time for our listeners, the article that we've been discussing during this episode can be found in the Journal of Addiction Medicine in the March-April 2024 issue. Thank you for joining us.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.